Welcome back. But let all that but let all those that put their trust in thee rejoice. Let them ever shout for joy, because you defend them. Let them also that love thy name be joyful in thee. Psalm 5:11. So, last time, I'm not sure what I said about pulmonary artery and vein. Basically, the question was angiotensin 2. Um, is it higher? Where is it higher? And it's higher in the pulmonary vein than the pulmonary artery. This is because there's more pressure on the left side of the heart. So angiotensin 2 is higher in the pulmonary vein than the pulmonary artery. So where is the pulmonary vein? Pulmonary vein goes from the lung to the left atrium, right? So the angiotensin 2 is higher there because there's more pressure on the left side of the heart. So pulmonary vein takes the good blood from the lungs to the left atrium, right? And pulmonary artery is between the right ventricle and the lung. Right ventricle, yeah, uh, between the right ventricle and the lungs, and the pulmonary artery takes the bad blood to the lungs from the right ventricle. So angiotensin 2 is higher in the pulmonary vein, okay, than the pulmonary artery. Okay, next. We did CHF. Basically, what happens in congestive heart failure? This leads to decreased cardiac output, which leads to increased RAS, which leads to increased sympathetic stimulation, which leads to increased renin, which leads to increased angiotensin 1, which leads to increased angiotensin 2. This leads to systemic vasoconstriction and efferent arterial vasoconstriction. Okay, that's how your body tries to fight back when your heart is failing, by efferent arterial vasoconstriction to increase the BP in the body. Okay, 150. A 13-month-old boy is brought to the ED. He has recurrent otitis media, pneumonia, and oral thrush, chronic diarrhea, and failure to thrive. He is tachypneic and has perioral cyanosis. X-ray shows bilateral interstitial opacities. Bronchoscopy shows pneumocystitis cerevisiae. This kid has SCID. Okay, what is SCID? Let's see. So SCID is okay. So adenosine deaminase deficiency. Adenosine deaminase is required for the degradation of adenosine and deoxyadenosine. Decreased adenosine deaminase will lead to increased DATP, which leads to decreased ribonucleotide reductase activity. This leads to lymphotoxicity. Okay. Right, so lymphotoxicity. Being toxic to lymphocytes. Okay. So this if you have adenase deaminase deficiency, you have a defect of lymph. Okay. Alright. You have defects of the lymph, and one of the major causes, the adenosine deaminase deficiency is one of the major causes of SCID. 1 minute break. Okay, so Okay, sure, it's good. So, there's several types of SCID, including defective IL-2R gamma chain, which is most common. This is X-linked recessive. Then there's SCID due to adenosine deaminase deficiency. That is autosomal recessive. It's due to RAG mutation, which causes VDJ recombination defect. Presentation is a failure to thrive, chronic diarrhea, thrush, recurrent viral, bacterial, fungal, and protozoal infections. The findings: you have decreased T cell receptor excision circles. Decreased T cell receptor excision circles. You have absent thymic shadow on chest X-ray. Okay, suck. So, we have absent thymic shadow on chest X-ray, and germinal centers, lymph node biopsy, and T cells flow cytometry. Basically, what that means is um, the B cells will be absent in the germinal center, and T cells absent in the paracortex. Okay. We'll get to this when we review immuno. Basically, in SCID, you have in the germinal centers, the B cells will be absent in the germinal center, and the T cells will be absent in the paracortex. Okay? And you can see this on lymph node biopsy. And the T cells you can see through flow cytometry. So flow cytometry is when the WBCs, which are B cells, macrophages, are passed through a tube and laser to count how many CD4 plus and CD8 plus T cells are there. Basically, the T cells will be absent in SCID. Okay, so in germinal center, the B cells will be absent, in the and the T cells will be absent in the paracortex. Maybe I can show you where that is here. So cortex, germinal center of lymph node, B cells. Okay, so okay, so this is the lymph node where the germinal centers. I'm waiting for the picture to clear, but apparently it's not clearing. Okay. Alright, so this could be a better picture. So these are the germinal centers in the lymph node, right? B cells are normally accumulated here in the germinal center, and you don't have B cells in SCID. So these germinal centers will be absent, and T cells are normally in the paracortex. Where is the paracortex? Right here. So this is the paracortex right here. Okay, the T cells are normally there, and the T cells will be absent in the paracortex. Remember this one, B cells in the germinal centers will be absent in SCID. See the germinal center here, the B cells, and the paracortex right here. So cortex is on the outside, right? That's where the germinal centers are. Paracortex means para means next to the cortex, so that's where this is paracortical area, mostly T cells right here. Okay, all right, next. So that's what this means here. TREC, T cell receptor excision circles. TRECs are normally found in working T cells, but if T cells are not working, they will not have TRECs. Okay, so basically in SCID there's no T cells, right? And that means that's why you won't have, you'll have decreased T cell receptor excision circles because there's no T cells. Alright? Okay, in somebody with SCID. Okay, so there's several types of SCID, including defective IL-2R, IL-2 receptor defect. So IL-2 receptor cannot work, so T cells cannot be made, and if T cells cannot be made, B cells cannot be made. Alright, so basically IL-2R, IL-2 interleukin 2R gamma chain, IL-2 receptor defect. So IL-2 receptor cannot work, so T cells cannot be made. Okay, so T cells can't be made, and if the T cells cannot be made, that means the B cells cannot be made. So remember, let me get back to my journal. Remember our original question, the patient has otitis media, pneumonia, and thrush, chronic diarrhea, and failure to thrive. He is tachypnic and has perioral cyanosis. X-ray shows bilateral interstitial opacities. Bronchoscopy shows pneumocystitis cerevisiae. Alright, remember how we said that was mostly seen in AIDS patients? Why? Because AIDS patients, they have almost no immunity, right? Their CD count is probably in the 50s. So that's why they have pneumocystitis cerevisiae, which is able to invade. It's a fungus, right? I believe it's fungus. Pneumocystitis cerevisiae. fungus. Okay. So start the prophylaxis. This is you start the prophylaxis when CD4 count drops below 200 in HIV patient. Yeah, so somebody with AIDS, it'll be lower. So that's why I said like a CD4 count of 50. So somebody with SCID, they don't have B or T cells, so you can imagine how it affects SCID patients. Okay. All right. Okay. Um, okay. So a SCID, it's an excellent and autosomal recessive. It's a failure of T cell. It's a failure of T cell development. So you get viral, fungal, and opportunistic infections. And the B cell dysfunction there's B cell dysfunction due to absent T cells. So T cells are required for B cells to produce IgG and IgA. SCID patients have impaired humoral immunity, which presents as recurrent sinopulmonary bacterial infections. So SCID patients have impaired humoral immunity, which presents as recurrent sinopulmonary bacterial infections, pneumonia, otitis media. They also have chronic diarrhea due to decreased IgG and IgA. Recurrent infections cause failure to thrive. Okay, so T cells are required for B cells to produce IgA and IgG. SCID patients have impaired humoral immunity. Yeah, SCID patients have impaired humoral immunity, which presents as recurrent sinopulmonary bacterial infections, like pneumonia, otitis media. They also have chronic diarrhea due to decreased IgA and IgG. Recurrent infections cause failure to thrive. Yeah, which presents as recurrent sinopulmonary bacterial infections. So chronic diarrhea due to decreased IgA and IgG. Recurrent infections cause failure to thrive. Okay, so SCID is due to RAG mutation, which causes VDJ recombination defect. Okay, alright, next. 151, woman gets candida antigen injection into the skin, and her skin produces 12 milliliters of skin in duration within 48 hours. Which of the following cells are directly involved in the effector response in this woman? This is due to CD4 T lymphocytes and macrophages. Yeah, so this is due to CD4 T lymphocytes and macrophages. The Candida antigen test checks for activity of cell-mediated immunity. Yeah, the Candida antigen test checks for activity of cell-mediated immunity because this test requires an intact CD4 cell response. Candida triggers a delayed type 4 reaction, which allows the evaluation of cell-mediated immune response. Injected Candida antigens are taken up by APC, which are the dendritic and macrophages. These macrophages display the antigen on an area called MHC. and the macrophages present this antigen 1 to CD4 cells. So CD4 cells differentiate into type 1 helper cells, which secrete TNF and interferon gamma, which activates macrophages. These macrophages phagocytize candida antigen and secrete inflammatory mediators, producing cutaneous inflammatory response that appears as integrated wheal in 24 to 48 hours. So because exposure to candida is everywhere, all healthy patients have memory T cells. All healthy patients have memory T cells against candida. Patients with SCID have T cell dysfunction, so they will not they will show no skin response to candida challenge. So basically, in healthy patients, the proper immune system, with the proper immune system, you will have PBD. You will have a PBD reaction. Candidates. So this is a normal reaction. Somebody that has an immune system, and somebody with SCID, they won't have this because they have no T cells. Okay. Candida triggers a delayed type 4 reaction, which allows evaluation of cell-mediated immune response. Injected Candida antigens are taken up by APC. These in APC, which are macrophages, display the antigen on an area called MHC. The macrophages present this antigen to the CD4 cells. CD4 cells differentiate into type 1 helper, which secretes TNF and interferon gamma. CD4 cells differentiate into type 1 helper cells, which secrete TNF and interferon gamma, which activate the macrophages. These macrophages phagocytize candida and secrete inflammatory mediators, producing that skin response that shows up like PPD 24 to 48 hours in 24 to 48 hours. Okay. Macrophage presenting antigen from MHC2 T helper. So So this is a antigen presenting cell, which is a macrophage. It has an area. This green, okay, so this green thing is the macrophage, and it has area on it. This is the red. I call it MHC, and that's the red part. And this MHC is attached to the macrophage. Okay, and this antigen, which is candida in this case, is this yellow thing. Macrophage grabs the candida by using MHC1, and then the macrophage takes that to the T cell, which is this blue thing. Um, and then the T cell secretes the TNF, tumor necrosis factor, and interferon gamma, which calls more macrophages to the site of action to fight the candida. Okay, so remember this, right? There's MHC1 and there's MHC2. Next, 152. 34-year-old is diagnosed with rheumatoid arthritis 3 months ago and started on methotrexate therapy. Despite treatment, she continues to have several hours of morning stiffness, daily and frequently awakes at night due to joint pain. PE shows swelling and tenderness in joints of the hands and feet. Etanercept is added to the regimen. Etanercept is characterized by what? Etanercept is a soluble receptor decoy protein. Okay, so etanercept is a TNF alpha inhibitor added to methotrexate to treat severe rheumatoid arthritis who failed on methotrexate alone. So etanercept is a TNF alpha inhibitor added to methotrexate to treat severe arthritis, severe rheumatoid arthritis who failed on methotrexate alone. So etanercept is a receptor molecule. Etanercept is a fusion protein linking a soluble TNF alpha receptor to the Fc part of human immunoglobulin. Etanercept decreases biological activity of TNF alpha by acting as a decoy protein. Okay, so etanercept etanercept joins TNF alpha to IgG. So it decreases the TNF alpha in the body, which it decreases the amount of TNF alpha attacking the body, so there will be a decrease in rheumatoid arthritis symptoms. Okay, it's a soluble receptor decoy protein. Okay. 153. A 10-year-old is brought to the ED because of increased lethargy and fever. For the past 12 hours, um, the boy was well last night, but sluggish in the morning, and his activity level and responsiveness decreases. Patient was treated for Neisseria meningitis bacteremia 2 years ago. He has 103.3 fever, tachycardic, has bruises and petechia on extremities. There is a decreased capillary refill time. What will the CH50 and AH50 show? So there will be decreased CH50 and decreased AH50 here. Okay. 154. 12-month-old boy has eczema. He has several severe respiratory infections that needs a hospitalization. The CBC shows a WBC at 9,000 and platelets at 40,000. Platelets seem very small and deformed on the peripheral blood smear. What is the diagnosis? This kid has a Wiskott-Aldrich syndrome. Okay, Wiskott-Aldrich syndrome. Is it not inverse dude? Oh, there it is. Okay, Wiskott-Aldrich syndrome. So this is a mutation in the WAS gene. Yeah, mutation in the WAS gene. Leukocytes and platelets are unable to recognize actin cytoskeleton. This causes the defective antigen presentation. And Wiskott-Aldrich syndrome is X-linked recessive. So there is an increased risk of autoimmune disease and malignancy. You have thrombocytopenia, eczema, and recurrent pyogenic infections. Okay. Findings. There's a decrease in normal IgG, IgM, and then there is increased IgE and IgA, fewer and smaller platelets. Okay. So Westcott-Aldrich syndrome, the mutation is a mutation in the WAS gene. Mutation in the WAS gene. Leukocytes, which are um, the antigen presenting cells like macrophages. And okay, so leukocytes and the platelets are unable to recognize the actin. Um, Leukocytes and platelets are unable to recognize the actin cytoskeleton, so the platelets crumble because there is no cytoskeleton. So that's why there's deformed platelets. Platelets are unable to recognize the actin cytoskeleton, so the platelets crumble because they have no cytoskeleton, and this causes defective antigen presentation. Yeah, exactly. So because the leukocytes are APCs, right? So they cannot present the antigen to the um, T cells. Yeah, the macrophages can't present the antigen to the T cells because their cytoskeleton is busted. Okay, all right. So that's why they had defective antigen presentation. This disease is X-linked recessive. Okay. Um, they lack actin cytoskeleton, so the ABC cannot be presented. So there is increased infections. So yeah, the antigens will thrive in Westcott-Aldrich syndrome. Okay. Um, Recurrent pyogenic infections because Aldrich syndrome forgets oh because this Aldrich syndrome targets the APC and the T cells and the platelets. So you have pus infections, pyogenic infections. Okay, because you have defective APC and platelets and T cells. So you have thrombocytopenia, eczema, and recurrent pus infections. There is increased IgE and IgA. You have to remember that. I guess I guess the way to remember this. See this rich Westcott-Aldrich syndrome. The way to remember which IGs are up in this, you had to think of somebody rich like Elon Musk. So IGE, Elon Musk, E for Elon Musk, and then A, he does AI stuff, right? Artificial intelligence. So just think of Elon Musk is rich, so IGE is up, and he does a lot of AI, so IGA is up. So the rest will be down, right? Or normal. Okay. So this right here, this won't be happening in Westcott-Aldrich syndrome, the antigen presentation. Westcott. Let's see, recurrent pus infections. Yeah, this is what they'll look like. Eczema. Okay, so that is what that is. Okay. Okay, so next. Oh yeah, so Wiskott-Aldrich syndrome is a combined B and T cell deficiency. There's recurrent infections that worsen with age, easy bleeding because of no platelets. You have eczema. You have recurrent pyogenic infections because of B cell deficiency, and there is no humoral immune response against organisms. So the severe recurrent infections develop after transplacental maternal IgG and maternal mucosal IgA decrease around 6 months of age. So basically, you're gonna if the kid has a Wiskott-Aldrich syndrome, you're gonna see it around 6 months of age. Once the mom's IgG and IgA stop working in the kid. Okay, so there's recurrent pyogenic infection that happen because of B cell deficiency, because there is no humoral response against organisms with polysaccharide capsule like Neisseria meningitis, Haemophilus influenza, um, and Streptococcus pneumonia. Okay, so remember this. Okay, there is increased chance of cancer here in Wiskott-Aldrich syndrome. Okay, all right. Next. What causes tachyphylaxis? Yeah, what causes tachyphylaxis in nasal decongestants? Um, this is due to increased receptor internalization. Okay, what causes tachyphylaxis in nasal decongestants? It's due to the increased receptor internalization. There is activation of adrenergic receptors, which results in the arrestin binding and receptor internalization. So the alpha and beta receptors undergo shape change, which activates the G proteins involved in signal transduction. Also, change in the shape leads to the binding of arrestin, and this stops further G protein activation. Okay. So stopping G proteins from interacting with alpha and beta receptors is what causes tolerance to develop. So stopping the G proteins from interacting with alpha and beta receptors is what causes the tolerance to develop. Stopping G proteins from interacting with alpha and beta receptors is what causes the tolerance to develop. This stopping of the G protein is caused by arrestins binding to stimulated alpha and beta receptors. This is due, okay. The rhinitis medication occurs if pseudoephedrine and phenylephrine is used more than 4 to 6 days. This is due to tachyphylaxis of intranasal vasoconstrictive sprays. Okay. So what causes tachyphylaxis and nasal decongestants? In increased receptor internalization. So alpha and beta receptors undergo shape change, okay? This activates G proteins involved in signal transduction. Also changes in shape leads to binding arrestin. Also changes in the shape. Also changes in the shape. Also changes in shape. Okay. Activity protein. Protein involved. The alpha and beta receptors undergo shape change. Activate G protein involved in the signal transduction. So basically, you have when you constantly use these nasal sprays, you're stopping the G proteins from interacting with the alpha and beta receptors, and this causes tolerance to develop. This stopping of G protein is caused by arrestins binding to stimulated alpha and beta receptors. And this happens with pseudoephedrine and phenylephrine if it's used more than 4 to 6 days. Okay, so let's look that up. Tachyphylaxis. So types of interactions: nitrate. You have nitrates. You have niacin, phenylphrin, LSD, MDMA. All this causes tachyphylaxis due to acute decrease in response to drug after. That's what tachyphylaxis is. It's an acute decrease in response to a drug after initial repeat administration. Some examples of drugs that cause tachyphylaxis: nitrates, niacin, phenylphrin, LSD, and MDMA. All right. Okay, so they just give first. They just gives an example of why, of how phenylephrine does that. It's due to increased receptor internalization. So then, the adrenergic receptors. So there's activation of adrenergic receptors, which results in arrestin binding and receptor internalization. Basically, stop the G proteins from interacting with alpha and beta receptors, and this causes tolerance to develop. Um, the stopping of G protein is caused by arrestins binding to stimulated alpha and beta receptors. The stopping of G protein is caused by arrestins. Okay. Binding to stimulated alpha and beta receptors. Okay. Um, rhinitis medication is due to tachyphylaxis of intranasal vasoconstrictive sprays. Okay. 156. Which antibiotic is which antibiotic paired with paroxetine would cause the serotonin syndrome? This is linezolid. So linezolid paired with the paroxetine would cause the serotonin syndrome. Linezolid is used for vancomycin resistant enterococcus. It's used in methicillin resistant Staph aureus, and it has MAOI activity. So linezolid and paroxetine will cause serotonin syndrome. Serotonin syndrome develops when MAOI antidepressants or non-antidepressant with MAOI activity, like linezolid, is combined with SSRIs or SNRIs or TCAs. So paroxetine is an paroxetine is a SSRI. Paroxetine. Yeah, it's a SSRI. So this will increase the serotonin in your body, and when this is paired with a non-antidepressant with MAOI activity, like linezolid, you will get serotonin syndrome. And serotonin syndrome is hyperthermia, hypertension, tachycardia, altered mental status, tremor, hyperreflexia, myoclonus, diarrhea, vomiting, and diaphoresis. So what is myoclonus? Muscle jerks. So they are muscle jerks, okay? So linezolid. So it's used for vancomycin resistant enterococcus, and it can also be given for MRSA, methicillin resistant Staphylococcus aureus. But to make sure the patient is not on paroxetine or any SSRI or SNRI or TCA. 157. Patient presents with sudden onset right arm weakness and difficulty speaking. Okay, take a 2-minute break. Okay, no, 5 minutes. 5-minute break. Okay, guys, sorry. Uh, had to attend to some wedding planning stuff. Okay. If you know anything about Indian people and weddings, you know it's extremely hectic because there's like 1,000 people invited to the wedding. But yeah, let's see. Now, where were we? Okay. Patient presents with sudden onset, right arm weakness, and difficulty speaking, which resolved in 20 minutes. The carotid Doppler shows mild left common carotid artery. The carotid Doppler shows mild left common carotid artery. Carotid Doppler shows mild left common carotid artery stenosis. If the patient has started on an additional med for her condition, which adverse effect would occur? On an patient has started on an additional medication for her condition, which adverse effect would occur? Okay, fine. So basically, um, this patient has had a stroke, right? Mild common carotid artery stenosis. Patient has started additional medication, which adverse effect would occur. Okay, this patient had a stroke. If she started on something else, an additional medication, what would happen? So basically, if you give aspirin, right? If you give aspirin for her stroke, what is the adverse effect of aspirin? It's a GI bleeding. Yeah, you get a GI bleeding, uh, which is a side effect of aspirin. This is due to COX-1 inhibition, which results in impaired prostaglandin, uh, which which results in impaired prostaglandin and decreased synthesis of thromboxane A2. Okay, so basically, aspirin causes COX-1 um, inhibition, and that causes a decreased prostaglandins and a decreased thromboxane A2. Okay, what does prostaglandins do? Okay, um, prostaglandin is important for protecting the gastrointestinal mucosa. Okay, all right. And thromboxane A2 does the platelet aggregation. So when you give a COX-1 inhibitor, you impair prostaglandin synthesis and you decrease TXA2. So basically, uh, you decrease the prostaglandin, so there is no GI protection. So now you have GI bleeding, and you also decrease the number of platelets. So now you have because that's also a decrease in TXA2, which is thromboxane A2, is also a side effect of aspirin. All right. So yeah, so basically now the reason you give aspirin is to decrease the platelet aggregation. But unfortunate side effect of that is GI bleeding also. So that's why this patient had a transient ischemic attack. So you give low dose aspirin to prevent ischemic stroke in TIA patients. Only COX-1 maintains gastric mucosa, and COX-1 deals with TXA2 production. Okay, so aspirin you had to know is a COX-1 inhibition, and that decreases the prostaglandin and the TXA2 in our body, and the side effect of that is GA bleeding. Okay, very important. Okay, 158. Um, okay, 158. A 47-year-old male has muscle weakness and dark urine for a few days. He is being treated for H. pylori. He shows diffuse muscle tenderness. Lab shows increased BUN and increased creatinine. UA shows no RBC or WBC. What medication causes man's condition? Okay. So this patient is on clarithromycin, which inhibits the CYP3A4. So statin levels will increase. The statins except pravastatin, for the most part, are metabolized by the CYP3A4. So the statins would increase, leading to statin myopathy. Ketoconazole, non-dihydropyridine, calcium channel blockers, and amiodarone all inhibit the CYP3A4 and lead to statin myopathy. So, clarithromycin, which is one of the treatments for H. pylori, inhibits CYP3A4, so the statin level will go up. Okay. So statins are broken down by the CYP3A4. So this patient was on statins. Okay. And that's why, the patient was on statins. Okay. So clarithromycin inhibits CYP3A4. So statin levels go up. Okay. Okay, so statins are broken down by the CYP3A4, and then clarithromycin comes and inhibits the CYP3A4, which, so then now there is nothing to break down these statins. So the statins build up in the blood, and this causes statin myopathy. That's why this patient has muscle weakness, and increased creatinine, and muscle weakness, because this is statin myopathy. All right, one second. Come back. Let's go. Come on. No. Who is scared of thunder? Bye bye. Okay, so let's see. What is the reason for high dose of oral nitrate compared to sublingual nitroglycerin? What is the reason for using high dose of oral nitrate compared to sublingual nitroglycerin? Okay, what is the reason for using high dose of oral nitrate compared to sublingual nitroglycerin? There is a high first pass metabolism when you use oral nitrate. High first pass metabolism when you. So the question is, what's the reason for using high dose of oral nitrate compared to sublingual nitroglycerin? And the reason is because there's a high first pass metabolism. So isosorbide dinitrate is absorbed by the GI and then undergoes first pass metabolism in the liver. Okay, isosorbide dinitrate is absorbed by the GI and then undergoes the first pass metabolism in the liver and then goes to the systemic circulation. This is what leads to decreased bioavailability. So much increased doses is needed when then the sublingual nitroglycerin, which is what you put under your tongue. So sublingual nitroglycerin is the drug of choice for fast relief and prevention of angina before exercise. Nitroglycerin is absorbed rapidly from the oral mucosa directly into the venous circulation and has a rapid onset of action within 2 to 5 minutes. That's why the sublingual nitroglycerin is preferred, because if you use the oral one, it undergoes the first pass metabolism. What is first pass metabolism? Let me show you. Alright, so first pass metabolism is this. First pass. Okay. First pass metabolism is this, okay? So basically, you take the drug, you eat the drug, and then it goes into your GI tract, right? And a lot of that drug is broken down by the acid. That's how I understand it. Then it goes to your liver. It goes through a bunch of things before it goes into your body to be absorbed. This is the oral one, okay? All right. So first absorbed by the GI, that undergoes first pass metabolism, then goes to, So it's absorbed by the liver. It's absorbed by the GI, and then undergoes the first pass metabolism in the liver, and then goes to systemic circulation. So basically, it goes to your GI, then it goes to your liver, then it goes to your body. So it's broken down a lot before it gets into your blood, and that's why the oral nitrate has decreased bioavailability. Okay. All right. Isosorbide nitrate has decreased bioavailability because of the liver. It's absorbed in the GI first and then goes to the liver, which is why nitrates have decreased bioavailability. So nitrate is swallowed, absorbed in the GI tract, and then goes to the hepatic portal vein where nitrates are metabolized. This is why only a small percentage of the active drug goes into the systemic circulation. This decreases the bioavailability. First pass metabolism greatly lowers the bioavailability of the drug. So you need to give increased dosage if you're giving the oral form. Okay? Alright. Let's see. Chronic stable angina. Nitrates. So for chronic stable angina, you give nitrate, beta blockers, and calcium channel blockers, okay? Chronic stable angina, you give nitrates, beta blockers, and calcium channel blockers. So what is stable angina? Oops. So stable angina, what's that? Stable angina. Okay. So stable angina, this is, see this? Stable angina is this. Okay, so stable angina, oops. Okay, so stable angina is episodic. So this one happens when you have you're exercising and then you suddenly get chest pain, but it's relieved by rest. Okay, so last 2 to 5 minutes. All right, so that's the one that's stable. You give nitrates, beta blockers, and calcium channel blockers. Let me just make a note. Okay. Occurs on exertion, relieved by rest. Okay. Occurs on exertion, relieved by rest. Okay. Okay. And then unstable angina. Unstable angina is unstable, occurs at rest. Occurs at rest. So think of something. Think of someone unstable, unhinged. So that person, even if you do absolutely nothing, will come bother you. Think about it that way. Somebody unstable, unhinged, sitting somewhere doing your own thing, will come and attack you. Just think of that. I can't think of it. I always get mixed up between stable and unstable. Stable is like you do something and then it attacks you, right? So if you do exercise and then it attacks you, it's stable. Okay. So the other one is okay. So basically, for stable angina, you give nitrates, beta blockers, and calcium channel blockers, and that's the one that occurs at rest, the chest pain that occurs at rest. And you give the reason you want to you like to give sublingual nitroglycerin, so that you would like to give sublingual nitroglycerin to avoid the high first pass metabolism with oral one. Okay. The first pass metabolism greatly lowers the bioavailability of a drug, so you need to increase the dosage. All right, we are going to stop here at 160 and then continue with the next video. Okay. Let's see if we can crack 200, because all this is it requires explanations with first aid. That's why it's taking longer, but it'll be worth it. Okay, don't worry, it'll be worth it. All right, bye.